I think that we can make a start. We're already 20 minutes late. So I would like to invite Jackie Newton, a neurosarcoidosis patient who is a Sarcoidosis UK trustee. And I would like to thank for the participation Dr. Victoria Sincari, who's a consultant neurologist participating in the Joint Neurosarcoidosis Clinic. I must say that I have a privilege working with her, which has improved significantly my understanding about the neurology aspects of inflammatory conditions, and more specifically sarcoidosis. Should we move on with Jackie's video?
Hello everyone. So my sarcoid journey has been a long one since I was 2 years old. And I've been diagnosed, or rather undiagnosed and misdiagnosed many times with sarcoidosis. My main sarcoid manifestation is spinal cord sarcoidosis. I've found over the years that the best thing to do is to be honest with your GP, ask for a referral to a neurosarcoid doctor. Either they could have an interest in neurosarcoid or they'd be willing to learn about neurosarcoid. But the main thing is that it is such a different disease to other neurological conditions that really having someone who understands it will be your best chance of the right treatment and recovery. I would just advise you to find someone, and you can do that either by joining our private Facebook neurosarcoid group, which is a great support group for anyone with neurosarcoid. And even if you just suspect you've got neurosarcoid, you're welcome to come and join us. And you can also find details on by phoning our superb team at Sarcoidosis UK, who have details of interested doctors.
Thank you very much. Vicky, should I hand over to you, and then Jackie could ask a few questions?
Yeah, let me try and share my screen.
Great, we can see your screen. If you can take it to presentation mode, it would be great.
That working all right?
Yeah, great, thank you.
Okay, thank you first of all, Vasilis, for that kind introduction, and thank you Sarcoidosis UK for inviting me to speak today. It's an honour, and thank you, Jackie, for that lovely summary of a patient's experience. I'm going to keep this relatively brief, and I have tried in these slides to address some of the questions that I've seen, but I'm sure that if I fail to touch on something or fail to elaborate enough, that Jackie will question me further in regards to those points. So first of all, and I'm sure that you know this already, but sarcoidosis is considered to be a hyperactive immune response where T immune cells, which are a type of white blood cell, release immune proteins which activate macrophages, which are another type of white blood cell, which leads to granuloma formation. So granulomas are collections of macrophages which clump together and form tiny nodules. And here's a histological specimen of a granuloma in the membranes around the brain. Granulomas can also occur in response to certain infections as well, but usually when they form in response to infections, there's necrosis or dead tissue within the granuloma, which is not the case here and is not the case in sarcoidosis. Granulomas can occur in any organ, as you've heard already, and this includes the nervous system. So neurosarcoidosis can affect 5 to 15% of patients with sarcoidosis. However, only 1% of patients with sarcoidosis will have sarcoidosis confined to the central nervous system. Sarcoidosis can affect the brain, the spinal cord, the meninges, which are the membranes around the brain and spinal cord, the cranial nerves that supply the face and the eyes, and control swallowing and articulation can also be involved. And so can the peripheral nerves that go to the arms and the legs. More rarely, it can affect the muscles as well, but this is much rarer. It can also affect the small fibers which mediate pain, and it can also affect the blood vessels which supply the brain, causing strokes. The symptoms produced by neurosarcoidosis will depend on which part of the nervous system has been affected. So damage affecting the brain can cause weakness or numbness, depending on where the involvement is. It can cause balance problems, vision problems, swallowing problems, speech problems, and cognitive problems. Can also affect the automatic functions, particularly if there's involvement of the spinal cord or the peripheral nerves. And this includes control of bladder, bowel, sexual function, but also blood pressure and heart rate control and temperature control as well. So if you're suspected of having neurosarcoidosis because you're experiencing some neurological symptoms, one of the first tests that you'll have is likely to be an MRI scan. So this is an MRI scan going through the bottom of the brain. So you see the bottom of the brain here, nose and the eyes. And this white area here is taking up contrast, so the gadolinium that's injected during a contrast MRI scan. And this area is all abnormal. So this is inflammation or granuloma formation in the meninges around the brain, at the bottom of the brainstem, causing pressure on the brainstem and the cerebellum, which controls balance. You may also have a CT PET scan to see how active your disease elsewhere is. If you're complaining of numbness or tingling in the arms and legs, and perhaps if no cause for those symptoms has been found on imaging of the brain and the spine, then you might have nerve conduction studies performed. And this involves delivering an electrical impulse to the nerve and then recording from the skin or the muscles to see how those electrical impulses are conducted down the nerve and to see if the nerve is intact and functioning as it should be. You may also have a lumbar puncture, which involves a needle through the very bottom of the spine. So after the spinal cord is finished, but in the space where the nerves are, and there's lots of spinal fluid there, and it's a safe procedure. Obviously going in higher up puts risk of damaging the spinal cord or other structures, but down here, the nerves just slide out of the way when the needle is introduced, and it's safe to collect a sample of the spinal fluid. And the spinal fluid will be analysed for cells and proteins, which can indicate inflammation. Infection obviously can also cause increase in proteins and cells in the spinal fluid and cause lesions in the brain or the spinal cord. But we can look for particular organisms, so for viruses, for bacteria, and for proteins that are associated with fungal infections and TB, for instance. So it's a very useful diagnostic test. You may also be sent for neuropsychological investigations because cognitive problems are a common feature in all kinds of neurological conditions, but they're very multifactorial. So cognitive problems, problems with the thinking processes and the memory can of course be due to damage to the brain. But other things going on in the body and surrounding the person can also have an impact on how we function cognitively as individuals. So for example, if you're in a lot of pain, if you're not sleeping well, if there's lots of stress going on around you, or there's anxiety or low mood, then that can affect how you attend to things and concentrate. And if you're not attending to things or concentrating, then you're not going to remember things and you're not going to be able to function as you ordinarily would. So with neuropsychology tests, they give pen and paper tests and computer tests designed to look at particular parts of cognition. And they can extract things which are due purely to attention and concentration problems, perhaps due to lots of other things going on around the individual or within the individual, and dissect out what's due to perhaps organic or lesions involving parts of the brain, as opposed to other things which might be contributing. How about diagnosing neurosarcoidosis when there's no other organ involvement? So here I have some scans, or a scan from a patient with sarcoidosis. So this is a post-contrast scan, which shows that there's activity in the meninges, in those linings around the brain, which is a fairly common feature of sarcoidosis when it affects the nervous system. And here I have a scan from a patient with multiple sclerosis, and these are the typical lesions that you will see in multiple sclerosis. So this is the surface of the brain, the cortex. These black areas here are the fluid-filled ventricles of the brain. And these white areas here, which are oval shaped and oriented perpendicular to the lateral ventricles, are MS lesions. And these lesions are typical of MS lesions. Now, lesions in sarcoidosis can look a little bit like this as well, but it would be unusual, very unusual for an MS patient to have leptomeningeal, so involvement of the meninges around the brain. And we may then also look at the spinal fluid. So there are differences in the proteins that we can find in patients with MS as opposed to patients with sarcoidosis. So this is another important piece of information in terms of making the diagnosis. You may also have a CT PET scan to look hard for any evidence of other organ involvement, even if you have no other symptoms elsewhere in the body. But in instances where there's diagnostic doubt, then a brain biopsy may be considered. Now, brain biopsy is only undertaken in certain circumstances where the clinicians in the MDT are happy that the benefits outweigh the risk. So with any surgical procedure, there's always a small risk of infection, even though everything is done to try and prevent that from happening or treat it if it does arise. But obviously, as you can imagine, if infection takes hold in the brain, then that can lead to devastating consequences potentially. You also have to take into account the area of the brain or the spinal cord that's been biopsied. So for example, a biopsy from the motor cortex or the spinal cord is likely to cause some kind of fixed deficit following that, because those important motor neurons have been removed. So generally speaking, brain biopsies are only undertaken when there's a concern about malignancy, so cancer or lymphoma. And I'm sure that many of you at presentation may have been told, that they were suspicious that this might have been due to lymphoma or cancer. The same is true when there are brain lesions, and if there's nothing else going on elsewhere in the body to guide towards a diagnosis of sarcoidosis. So when lymphoma or other cancers are on the list of differential diagnoses, then that's the instance when brain biopsy is strongly considered. Because you can imagine that making a prompt diagnosis of lymphoma involving the brain or another brain tumor, starting treatment as soon as possible, appropriate treatment as soon as possible, is extremely important. And in those instances, the risks associated with performing a brain biopsy the benefits of performing the brain biopsy far outweigh the risks. So moving on now to treatment. As you're all aware, steroids are the first line treatment, including for neurosarcoidosis. If there's neurological involvement, we're always going to want to give a course of intravenous methylprednisolone over 3 or 5 days, and that will be followed by oral prednisolone. If there's neurological involvement, then you're very likely to need a second line treatment as well, because the duration of treatment is often, in the case of active neurosarcoidosis, for years rather than shorter durations of time. And obviously we want to bring the dose of steroid down to the lowest dose possible. So we will then introduce drugs like methotrexate or mycophenolate, azathioprine, leflunomide or hydroxychloroquine. In instances where these medications are not enough to bring the dose of steroids down, then we may consider escalating treatment to the anti-TNF treatments. So TNF is an immune protein which accelerates or contributes to the inflammatory process, and these medications dampen down inflammation by binding to TNF. And these drugs include infliximab and adalimumab. If there's still activity despite this, or these medications are not tolerated, then sometimes cyclophosphamide, which is also used as a chemotherapy treatment, or rituximab, which is another monoclonal antibody treatment, may sometimes be used to treat neurosarcoidosis. Now, not all neurological symptoms in sarcoidosis are neurosarcoidosis. So here I have an MRI scan of a lumbar spine, the lower back. This is the front of the patient, this is the back. As you all know, steroids can accelerate osteoporosis. And here we have degenerative change, a collapsed disc due to osteoporosis involving the spine. And there's also a disc prolapse, which is impinging upon the nerves that go to the leg. So this situation could cause numbness and weakness in the legs and bladder and bowel disturbance as well. But it's not due to active neurosarcoidosis, it's due to the complications of the treatments of sarcoidosis. Steroids can also lead to diabetes, and diabetes is a very common cause of neuropathy. So diabetic neuropathy has to be considered when we find neuropathy in a patient with sarcoidosis who's on steroids as well. And here we have an example of other granulomas affecting the brain, so necrotizing granulomas in the brain due to infection, due to a TB or fungal infection. And obviously all of these medications that are used to dampen down the immune response to try and stop sarcoidosis activity leave you more vulnerable to infection as well. So that's also something that needs to be considered. And then here I have someone struggling with fatigue and perhaps cognitive symptoms, but those symptoms, as I'm sure you already appreciate, are very multifactorial as well. They can be exacerbated by sarcoidosis activity going on elsewhere in the body, by what's happening around you as an individual. And so these things are not necessarily due to active neurological disease, but need to be addressed with other treatments. So symptomatic treatments and controlling these other factors. So I will close there and pause for questions now, if that's okay.
Thank you so much, Dr. Sincurry. That was amazing. That was so easy to understand, and you've done it very concisely and clearly. So I'm sure a lot of patients will have their questions answered already that posted their questions to us. But there are a couple that I can send your way. Let's see.
Sorry.
Right, nice to meet you. It's lovely to meet you. And thank you so much for taking on the mantle from Dr. Kidd, because as you know, it's such a difficult thing to find an amazing angel like you doctors that are interested in sarcoid. And the team at the Brompton are obviously angels to everyone that attends with sarcoid. So we really appreciate it. Thank you.
Thank you very much. And it's a privilege as well.
Well, let's see if we can put you on the spot. So we have a question about is twitching a nerve system involvement? And I realised that I didn't give any symptoms whatsoever. So that one is a simple one. Is twitching a neurosystem involvement?
Yeah, so twitching can be caused by dysfunction of those peripheral nerves that we were talking about. So if it affects the face, then the cranial nerves. If it affects, the arms or the legs, then the peripheral nerves. But twitching, if it's around the eyes or if it's just fleeting in different parts of the body, isn't necessarily pathological. So it can be a very benign thing. So if you're tired or stressed, it's not uncommon to get twitching around your eye muscles, and I get that myself. Alcohol and caffeine can cause twitching as well. So it can be a marker of neurological dysfunction, but by itself, it's unlike or less likely to be significant. So if there's weakness as well, then that's a definite red flag that suggests that there is some neurological dysfunction. But twitching that comes and goes without any weakness, if it's confined just to one part of the body, is less likely to be of concern.
So I developed twitching when my neurosarcoid was flaring really badly. I had so many symptoms I couldn't couldn't explain them to any doctor because it was just a multitude. And that's why I said in the video, be honest with your doctor, because I found I never confessed very much at all. I would say, oh, I'm feeling very ill, I think sarcoid's flaring. And I wasn't very specific, but I think if I had been, I would have been taken more seriously, more quickly, and I would have been treated better than I was. And so it was my fault. So people don't hold back.
I would say that it's not your fault. So as clinicians, as doctors, particularly as neurologists, our focus is always on the history. And I say to medical students that history, and I think a lot of neurologists say this, history is the most important thing. So it is our duty to probe and ask you questions that might indicate that there's something else going on as well. And I guess I should clarify. So in your case, you had lots of other symptoms as well as twitching, but twitching by itself is less likely to be of concern. But everyone is individual, and everyone needs a thorough assessment before that is concluded, basically.
Well, this question is a two-part question, and you've already answered the first part, and it was how does sarcoidosis affect the central nervous system? So you've done that very well. The other part was what proportion of patients have this in conjunction with lung and heart issues?
So as I mentioned in the presentation, about 5 to 15% of patients who have sarcoidosis, and often that will be the lung in particular because it commonly affects the lung, will have neurosarcoidosis, but the reverse is quite rare. So it is unusual to have isolated neurosarcoidosis. So yes, neurosarcoidosis does commonly coexist with lung sarcoidosis particularly. And cardiac sarcoidosis too, but to a slightly lesser extent.
Thank you. So someone here, they're currently being treated with methotrexate and prednisolone, and they're being investigated for neurosarcoid due to classical symptoms, they say. They are waiting on the MRI with contrast of the head and spine, but they're concerned that neurosarcoid might not show in these tests. And if this happens, how do they make sure that the result is correct?
Okay, so first of all, they will need an MRI of the brain and the whole spinal cord, and it will also be important for them to receive that gadolinium, that contrast injection as well. Because sarcoidosis can not uncommonly affect just the membranes around the brain and the spinal cord. And if you're not given that injection of contrast, then that could be missed. So it's very important that you have an MRI scan with contrast. And then it may be useful to then go on to do a lumbar puncture to look for cells and proteins that might indicate that there's inflammation, because sometimes changes on MRI scans can be quite subtle and might be missed by radiologists or not given enough weight to by neurologists who don't have neuroinflammatory experience in terms of reporting scans. So a lumbar puncture can be another important piece of information. And as we said as well, nerve conduction studies may also be helpful to indicate that there's a dysfunction in the peripheral nerves rather than the central nervous system. What I would say is that it would be difficult to make a diagnosis of neurosarcoidosis if all of those things are normal and don't reveal any evidence of inflammation. I mean, sometimes we do use low dose immunotherapy for quality of life purposes. And, if you're having lots of symptoms, which include neurological symptoms, Dr. Karanis and I may sometimes introduce a small dose of steroid or hydroxychloroquine or methotrexate to try and improve symptom control. But I'd have grave concerns about escalating doses of immunotherapy if we didn't have any hard evidence, if you like, that there was neurological involvement. But it's important that all of these tests are done.
So you're saying that if there's no evidence, you would take the patient's account or their symptoms and maybe offer us a low dose just to see if that helped to improve this?
Potentially, in some circumstances. And we also have to bear in mind, as I said, that some symptoms may not be due to sarcoidosis. So for example, an MRI scan might reveal that there's degenerative change in the spine, which may be the true cause for the symptoms. We also have to take the patient as a whole as well, and try and get an idea of everything else that's going on around them, which might be contributing to how they're feeling at the moment. And we also do have a lot of symptomatic treatments that can help, that don't involve the risk that comes with immunotherapy. And sometimes that's the most appropriate action to take, rather than subject a person to the risks that come with increasing doses of immunosuppression.
So you would treat it as like you treat pain instead of using an immunosuppression. Is that what you mean?
Potentially, yes. Yes.
Someone's asked if they have bulging discs and degenerative disease, is it necessary to have a lumbar puncture? So I think you just answered that.
So if there's a clear cause for the symptoms that have been described and a deficit that might be found on examination, then a lumbar puncture is a slightly invasive test. So I'd only do it if it was necessary. So if I was happy that the bulging discs explained the symptoms and there was nothing else on the scan to indicate neurosarcoidosis or any complications of the treatment of sarcoidosis, then I wouldn't explore a lumbar puncture.
What would you suggest someone does if they do believe that they have neurosarcoid, but their doctor doesn't deal with neurosarcoid and they've told them they don't have it from the tests they've done?
Then I think it's reasonable to ask to be referred to someone who has an interest in neurosarcoidosis, to ensure that all of the correct tests are done in the first instance. So for example, making sure that MRI scans are done pre and post contrast, and to make sure that those investigation results are interpreted by someone who has experience in these conditions as well. So yes, I think it's perfectly reasonable to ask to be referred to a neuroinflammatory specialist who has an interest in sarcoidosis.
Yes. No.
Jackie, sorry to interrupt you. I'm just we're running a little bit behind time. So if you could try to bring the session to a close with a final question, please.
Well, let's choose one. How does neurosarcoidosis cross the blood-brain barrier?
So immune cells cross the blood-brain barrier, and so it's the immune cells and that then gain access to the brain and the spinal cord that cause inflammation. And as I alluded to as well, blood vessels can also be affected by granulomatous change as well. So sometimes we can see patients having strokes due to inflammation and granuloma formation in the blood vessels that supply the brain.
And do granulomas move around, or do they not disappear once they're no longer active?
So an area of damage in the brain, once it's there, is usually there. It may shrink as the inflammation is brought under control, and occasionally it may disappear. But usually, once a lesion is there, it's there. And the important thing is to make sure that the inflammation is controlled, and that lesion is not growing or causing problems elsewhere.
Thank you very much. That's been a lovely chat with you, and I hope that everybody's enjoyed it, because it is so much easier to deal with something when you understand it.
Yes. Thank you very much.